That's because we currently follow 12 adult patients with cystinosis. 6 of those have been seen continuously by myself and are now adults. 3 have some chronic kidney disease, but 3 have kidney transplant. And 6 adult patients have actually come to the clinic as adults, although I did see a couple of them when they were much younger, just on one occasion. And when I looked at how many patients I've been following over the years, I realized that I've seen 300 patient years of patients, and 1/5 of that have been adults. So this is a cartoon of the patients that we have seen in Calgary over the years, 23 in total, but 20 now. And on the top right, you can see a line which shows birth, diagnosis, first seen, if it's different, whether patients have had a transplant and whether when they've been last seen. You can see that 3 individuals actually have adolescent cystinosis, so they were diagnosed in their teens and significantly older. 3 that we no longer see include 2 that left the clinic a while back, and 1 person who may be known to you. They now live in Ireland, which is unfortunate for us, but very good for them because it's very green all the time there. And so, interestingly, there's 4 pairs of siblings, but all pairs are either boys or girls, so there's no mixed boys and girls. 8 children, young adults, average age 11 years, 12 adults, average age 32 years, but the oldest is 55, and he's a great guy. He had his transplant fairly soon after diagnosis, and he's had his kidney transplant for 40 years. And 8 have kidney transplants. They're all now adults. An average age of the first transplant, about 17 years for all comers, but the 3 that I've seen over the many years had their transplants at an average age of 20 years, and I'll come back to that in a bit. So I'm going to talk to you a little bit about health issues, perhaps some reasons for different reasons for adherence to medications, challenges of transition, a little bit about parents and life events. So we've talked a little bit about supplements that Paul has talked about, and what I've observed in adult patients is that as the kidney function goes down, the filtration goes down. Paradoxically, even though there's less being put into the tubules of electrolytes, sometimes more electrolyte supplements, which is a bit difficult. Now, when you have decreased kidney function, often phosphate levels go high, but that isn't the case. And when you're an adult with Fanconi syndrome and decreased GFR, sometimes the adult nephrologist would be rather curious to see that actually you continue to need phosphate almost up until needing dialysis because of that phosphate leak. So that's an interesting phenomenon. Paul has already referenced this European cohort paper from Francesco Emma, 453 patients, and they divided the eras up into 4 essentially. The first 2 really before cystamine was really used a lot, 1980s, 1990s, and then a couple of other eras where the cystamine has been used. So we've got quite a bit of data here to look at the effect of cystamine on various things and problems. One thing is the kidney function, and the kidney function obviously gets worse with age, and cystamic treatment delays but doesn't prevent the need for kidney replacement therapy. But the survival of kidneys, if you like, has improved, and so it's improved by about 9 years, and that's the red arrow from half the patients getting to end-stage renal disease or requiring a transplant compared from the early cohort of patients to the later cohort. And this is obviously very good, and you can see that line goes down to about 19 years. So that kind of corresponds with the patients that I've seen. Kidney transplantation also looked in a different way in relation to the white cell cysteine levels, and it's quite clear from the data that lower white cell cysteine levels produce less of a hazard. And on the left there you can see that the hazard for reaching end-stage renal disease is set at 1 with a white cell cystine level of 1. They didn't extend the graph much lower than 1, which I think probably that graph goes down, the hazard ratio goes down less than 1, but certainly above 1, the risk for end-stage renal disease increases. And this equates to something like a difference of about 4 years from levels greater than 1.8 to levels less than 1.2. 1.2 always seems to be a bit too high for me, and we try and have levels running about 0.5 in the clinic in Calgary or less. There's another set of data from the USA which looked at similar sorts of things, less patients, but over a similar sort of time period. But what was interesting in this paper is that the age of kidney transplantation for the latest cohort that they looked at was only about 14 years, which is somewhat different to the 18, 19 years or so in Europe. And it hasn't really got longer. I mean, later, the age isn't later for the more recent cohorts of patients. About 50% get pre-emptive transplantation without dialysis, and the dialysis duration is really quite short. And perhaps we'll hear a bit more about transplantation from Paul tomorrow. However, what has been shown, and this is probably across all transplant at 5 years post-transplantation, has improved with later eras from less than 50% or so, 50, up to nearer 70 or so. So there's some good news there. So I'm going to move away from kidney issues. Some adults will have kidney transplants, some won't have kidney transplants, but there's a whole host of non-kidney issues. And really the bottom line for this is that good adherence to cysteamine treatment, good white cell cystine levels reduce or at least delay the onset of non-kidney issues. So when we look at the adult complications of nephropathic cystinosis, there was a systematic review which got 128 articles together about adult patients. Some included children, but at least there was a couple or one patient greater than 20 years old. They tried to get the data to look at adult complications of cystinosis. And so I'm going to just take you briefly through some of the things that they talked about in this paper to illustrate that some things aren't particularly common and some things are relatively common. Cardiovascular issues not really traditionally associated with cystinosis. There may be some ECG abnormalities. I couldn't find this paper to actually look at what that meant. Vascular calcifications, which are clearly bad for the arteries, are relatively common, but are associated with other things that happen with patients with cystinosis, such as diabetes and transplantation. However, when they looked at the rate of calcification, it was associated with longer periods of time without cysteamine treatment. So cysteamine is probably important for your blood vessels. Skin issues, good news here, adults don't seem to get the skin issues that some kids have got in the past, and probably these skin issues are now not very common in kids either, because people recognize that too large a dose of cysteamine may be associated with these sorts of things. Endocrine issues are important. We've heard that low thyroid function is an issue. This paper reviewed and said that the onset seems to be about 13 years of age. I found that difficult because none of the patients I followed for 28 years or so have thyroid, underactive thyroid glands. And so I think that with good cysteamine treatment, and thyroid issues really should be much later. Diabetes is clearly an issue too, because the pancreas is affected. Glucose levels should be monitored, and it may be that you have some glucose intolerance even if you don't have overt diabetes. A measurement of hemoglobin A1C, which is a measure of the average glucose levels, if you like, it may well be important to monitor that. Prednisone steroids, which are often used post-transplant, will tend to exacerbate the glucose issues. Gastrointestinal issues has already been talked about quite a lot, and we all know about nausea and vomiting and decreased appetite and such like and so forth. But swallowing dysfunction was found when these authors reviewed the literature in up to 3/4 of patients, and reflux often will be found as well. And this is all a musculoskeletal issue, and certainly if you have very significant swallowing dysfunction, which means that you have difficulty getting nutrition and water in. Paradoxically, you may actually require a G-tube later in life because of significant swallowing dysfunction. But again, this is probably much less likely with good sustained treatment. Stephen also mentioned liver and spleen issues. These appear to be very rare and also less when sustained treatment became available back in the 80s, 90s. And doesn't seem to be causing any issues, and certainly none of the patients I see as adults have any definite liver or spleen problems. Haematology issues were also talked about. They're only case reports, so we don't really know the frequency of issues. Some low hemoglobin, which may be a little bit more than just from chronic kidney disease. Low platelet count, and certainly I've got a few patients where they run low platelet counts just at the lower limit of the normal range. And there's been at least one case report of low hemoglobin white cells and platelets, but exactly how common this is hasn't really been researched and may be worth looking into in the future. The musculoskeletal issues have been talked a little bit about already, but the myopathy, muscle weakness, can affect perhaps 50% or more of patients, and the hands are initially affected, swallowing and respiratory muscles. Less common after sustained treatment for sure. And it may be that it's just delayed, but respiratory muscles are clearly very important, and nighttime continuous pressure may be needed, CPAP, which there's one patient that I follow when it's been very effective in helping the symptoms of decreased breathing at night. Muscle strength in general is being researched a whole heap, and Robert Mack, I think he's around here somewhere, is going to be perhaps talking to us, or he can talk more about this. It's very difficult to treat, and whether or not carnitine helps or anabolic steroids, it's very difficult. We may be hearing more about that in 2 talks tomorrow. Swallowing issues referred to already, and there's a whole host of symptoms which can be an issue. Traditionally, this is investigated with barium swallowing, which is something which is rather difficult to do, not necessarily the thing that can be done repeatedly, but a recent paper has described a scoring study which is non-invasive, where someone takes a cracker and eats it, and you observe how many times they need to chew on it before they can swallow it, and also drinking a certain volume of water, and this produces a Thomas score. This may be referred to tomorrow, I don't know, but I'm certainly thinking about introducing this for the adult patients in the clinic as well, to try and get a handle on whether or not there's issues or not. We've already heard a little bit in rickets in children, but for adults, it may be that it's less common than muscular issues, but there does seem to be a higher incidence of fractures. I can only recall one patient in the clinic who had fractures, and she had particular problems with acidosis, and that seemed to be the main issue causing her even spontaneous fractures. But the bone problems seem to occur in up to 70% of patients if you lump together fracture, deformations, and bone pain. Scoliosis, spinal curvature seems to be a bit more frequent. Bone mineral density, there's various reports about it being higher or lower, and not particularly consistent, and that's really the measure of the amount of calcium in bones. But there's been a fairly recent paper showing that the cortical bone, the outside part of the bone, is thinner and perhaps leading to less strength and more fractures. Neurological issues, the central nervous system is affected. We've heard about the intracranial pressure issue. Peripheral nerves don't seem to be affected, but learning, brain processing, visuospatial clearly can be an issue for brain function.
Mood and effects of illness is clearly a big issue, and this was looked at in Guy's Hospital, the bottom line was that adult patients with cystinosis had higher anxiety scores and depression scores. Certainly everybody's been more anxious and depressed during the last 2 years, mainly because we haven't been able to meet, I guess, but there's been something else going on. Complications of cystinosis and side effects of cysteamine itself can also impact relationships, autonomy, and social life. And this psychosocial aspect of cystinosis is clearly an issue for personal work and academic. It's related to the repeated medication taking and perhaps halitosis. Social supports are very important for families, and to some degree evolving independence as an adult as well to help with mental health and such like. So let's talk a little bit about transition. We've already heard from a few people about transition. Transition is all about moving from a pediatric medical system to an adult medical system. I'm not going to go through this diagram, but this is to illustrate we have a whole bunch of things: finance, coverage of medications, a change in education, a change in relationship to parents, a change in the healthcare providers. And we all know that transition occurs in adolescence, and adolescents have a particularly bad brain. It's all about the birds and the bees, and we have all the answers, and we definitely fit in all the time. And this is a problem for adolescents. We all know that, and we might even be able to remember when we thought we were omnipotent and were never going to get sick and such like and so forth as a teenager. But the problem is that there are a couple of small areas, decision making and judgment gland, which unfortunately are involved in healthcare decisions, and the teenager's brain, just perhaps isn't quite as good as it should be, which is clearly an issue. And the maturing brain perhaps doesn't really get there until 25 or so, and that's unfortunate because transition occurs perhaps at 16 or 18 years. And these transition issues of graded independence, with a whole bunch of other things going on, are helped by the pediatric clinic understanding that there's going to be a change and dealing with that and adjusting their way of looking after the children. Perhaps some combined clinics where you have the adult providers and the pediatric providers in a clinic simultaneously. And then perhaps a navigator. There's some studies which have shown navigators to help with adjustment or adaptation to adult care. And transition is difficult, there's no doubt about it. The adult clinic involvement may be very difficult as well because, as we've heard, not all adult nephrologists, actually very rare adult nephrologists, know very much about cystinosis. And so the young adults and families may be educating the adult nephrologists. And there needs to be some willingness to be acceptable. There needs to be an emphasis on psychological well-being and really a role for parents of the young adults as well. We don't want parents excluded. And transition in cystinosis is particularly difficult because it's rare. There's adherence to medication which may not be understood as well. And there may be multiple organs involved. So you may have a relatively small number of specialists, perhaps in the same hospital, in a pediatric setting, with perhaps a large number of specialists in perhaps different sites, which can be difficult. And there's confounders, physical and developmental confounders in cystinosis, which makes it more difficult. So with transition, it needs to begin early in adolescence. There has to be some sort of safety net after the transfer of care. We need to have inclusion of parents and identification of a suitable facility, which can be difficult. And protocols do exist, and papers have been written about how best to transition young adults to the adult system. Adherence to medication. Paul has talked quite a bit about how adherence is difficult with multiple medications. We know that there are 3 phases. Parents look after their kids completely at the beginning. Some people might say, well, perhaps we don't really want to call parents obsessive, but I think that parents can be very, very, very important and look after their kids very well. But then there's adolescence. That brain takes over the adolescent. The parents start to worry about their kids and whether or not they're taking the medication at school, and this can be very difficult. But as an adult, there is different motivation reasons for adherence. And I've tried to explain that really looking after your adherence to various medications, especially cysteamine, is so important for the various medical issues that can occur as an adult. So when we're thinking about improving adherence, it's understanding self-care promotion and making sure there's this facilitated transition to adult healthcare systems as identified in this review. Role of parents really is so important, and I can't emphasize more that I would like to have parents of the children, young adults that are transitioning to adult services being involved and not excluded from appointments. Some people think that there's medical privacy, access to results may be more difficult online and such like and so forth, but the role of parents of young adults and as well as adults is so important. And this is kind of illustrated by a cartoon where the parent is first and foremost in the early years and goes into the background as the adolescent takes over, but the parent still has to have some sort of role. It's just less upfront. But if you have a parent which sort of stays a little bit more too involved, that can be difficult. And if an adolescent isn't able to develop their independence with the parent backing them up, you may run into sorts of troubles. Adolescents move out. They move to university and college. This can be very difficult. They may want to rent, they may want to get married, they may want to have a family, and all of these sorts of things are going to be that much more challenging for people with cystinosis. Career choices are also difficult. We've heard today about people in IT for many, many years. I've met lawyers and teachers who've had successful careers. But there may be some cognitive function challenges which can perhaps make some careers a little bit more difficult. And certainly if you have a job such as a dental hygienist in mind, that might be difficult if you have some halitosis. Muscle strength is a little bit difficult. One of the patients I have been seeing for many years is becoming an electrician, and they're using their hands all the time, and that may be actually quite good for maintaining muscle strength. Tremor in medications for transplantation may also be a bit of an issue affecting career choices. So finally, I'm going to talk a little bit about fertility. We heard today that it's always been thought that most men with cystinosis don't have any sperm in their semen. But a recent paper showed that 3 of 15 patients, in other words 20%, actually did have sperm. And these were 18, 24 and 28 years of age. This is quite encouraging. There's an association between a non-57 kilobase mutation and having sperm in your semen. And this is probably because that big 57 kilobase deletion also affects other genes which may be involved with inflammation and therefore cause the testis to have more of an issue. And it's not that the sperm aren't being made. Over a long period of time, sperm may be less likely, perhaps into several decades of life. But sperm are in the testis. It's just that there seems to be an obstruction of the sperm getting out into the semen. But we've already heard that there has been reports of in vitro fertilization for fathering of children from a man with cystinosis. Endocrine testicular function or hypogonadism was noted, and the testosterone levels do decrease as the testes are affected by cystinosis. This can be corrected with supplementation. And this may be quite important for bone mineralization and muscle strength, although not that much is known about it. There has been some sort of idea, and endocrine diseases do seem to have this idea of latent dysfunction, where you can have normal testosterone levels, but the hormones involved with driving that testosterone to be at the right level are increased. Whether or not this needs to be treated, or whether or not it's something that the people making the testosterone want you to take, that could be an issue, and that hasn't really been explored as it says yet. Finally, I'm going to talk a little bit about pregnancy. We've already heard that pregnancy is possible. There's been many reports of successful pregnancies, but we really don't know for sure whether or not fertility in women is more or less, because there's just not been enough data. Of course, it's a recessive condition, and the non-infected partner has about a 1 in 200 chance of being a carrier. 1 in 200 doesn't sound particularly high, and that means that it's 1 in 400 chance of having a baby with cystinosis. But the outcome is so significant to potential parents that genetic testing is something that seems to be quite reasonable to do to show that there's no known mutation in the father. Certainly that's what we've done for the families that have been wanting to consider pregnancy in Calgary. So when we're dealing with pregnancy, there's a whole heap of planning that needs to happen. A high-risk obstetrician, I'm not sure that high risk is exactly right, but it's someone who would be paying a little bit more attention. Aspirin is often used because of an increased risk of preeclampsia, and certain medications such as ACE inhibitors, angiotensin receptor blockers need to be stopped prior to conception, and if you're transplanted, mycophenolate has to be substituted with azathioprine. Cysteamine, what we've done is stop the cysteamine when the pregnancy test is positive, because you have too much time without cysteamine. And there's been some signal in the literature perhaps about whether or not it should be restarted after all the organs are in place, because cysteamine certainly has been shown in animal models to cause a whole host of issues in mice and such like. And I'm very pleased that we have a patient in the clinic who has intact kidney function. She was diagnosed as a SIB to her sister, who was diagnosed before her, and she has very well maintained kidney function, around about 70-80% or so. Her first pregnancy went very well, a little premature, but she had relatively unchanged kidney function despite being off cysteamine for the whole of the pregnancy. The protein in the urine did increase. Her second pregnancy has recently been completed, and we did restart the cysteamine in the third trimester because of protein issues. But again, a very nice outcome to this pregnancy indeed. And I'll be looking forward to getting some publication to try and describe this for you. But what we did with this individual was we actually measured cysteamine in the breast milk once she started cysteamine after the pregnancy, and we found very, very low levels of cysteamine in the breast milk. So breastfeeding after a woman is delivered is perfectly fine to be on the cysteamine, which of course is very important. So conclusions, adult cystinosis is not easy, it's difficult. It's different but similar in some ways to pediatric cystinosis, and there's many potential medical issues, all of which seem to be much less cysteamine treatment and good adherence. I hope that kidney transplantation occurs in the third decade of life in the majority of patients with cystinosis. Perhaps with stem cell treatment early enough, it'll be prevented. Navigation from pediatric healthcare system happen, and even though I follow the patients in Calgary as they're adults, we still have issues with transition to the services such as chronic kidney disease and transplantation, which do require navigation. Effects on independence, moving out, career, psychosocial, and family issues. But with good support from families and community and the healthcare providers, things should work fairly well. Thanks very much for your attention.
Thank you, Dr. Midgley. Do you, we have